Hello, welcome to Labor and Delivery at Naval Medical Center, San Diego. We are so excited to take care of you and your family. Our care team consists of a group of practitioners who are all important in providing excellent and comprehensive care for you and your baby. Our leaders are our staff physicians, which are either active duty or civilian doctors who are board certified in obstetrics and gynecology. They have completed undergraduate, medical school, residency, and licensing exams. They oversee all actions and decisions of the physician care team. Our midwife practitioners are certified nurse practitioners who have completed a nursing degree, graduate school, and midwifery training, who are licensed as independent providers overseeing actions and decisions of the midwife care team. They may consult the physician care team if part of their labor course falls outside of their scope of practice. For example, when someone needs a cesarean delivery. Our anesthesia care team consists of staff physicians, nurse anesthetists, and residents who are all in charge of your epidural placement and pain control. Resident physicians are active duty officers who have completed undergraduate and a medical school degree and associated board exams to receive an MD or DO license. They are undergoing specialty-specific training in obstetrics and gynecology under the guidance of a staff physician. An intern is a resident who is in their first year of specialty-specific training in obstetrics and gynecology. Our nurses are registered nurses who are an integral part of your care team as both civilians and active duty service members. And our corpsmen are active duty service members who have undergone specific medical and on-site training to provide support in obstetric and newborn care under the guidance of the nurses and the physician and midwife care teams. Naval Medical Center is a teaching facility. We will often have medical and nursing students involved in patient care. This may include observation, the initial interview, and minor physical exam procedures under direct supervision of a practitioner. If you would prefer to limit learners in your care, please let your nursing team know. Often these learners are just observing what it is like to take care of patients on labor and delivery. Our goal here on Labor and Delivery is to have a healthy mom, a healthy baby, and a vaginal delivery. If there is a case where we are concerned about the health of you or your baby, an alternative route of delivery may be recommended with the goal of keeping you and your baby safe and healthy. Monitoring your well-being and your baby's well-being will include taking your vital signs, such as your heart rate, blood pressure, and oxygen saturation, as well as your baby's heart rate. We will also place monitors to measure your contractions, as well as 1 to 2 IVs to facilitate easy administration of medications. Later in your labor course, internal monitors may be placed next to your baby's head or on your baby's scalp in order to more accurately measure your baby's heart rate or your contractions. At NMCSD, we do have a standard birth partnership that includes delayed cord clamping for 60 seconds, the option for any of your support persons to cut the cord, gentle traction in order to deliver the placenta, and immediate skin-to-skin after delivery. Our pediatric team is not routinely present at delivery. However, under certain circumstances, we will request that they are there. If you would like to take your placenta home, we'll need you to sign a consent form as well as have a cooler available at time of delivery. However, there are certain conditions in which we recommend sending your placenta to the pathology team, such as preeclampsia, in order to evaluate for potential causes of these conditions. In these instances, taking your placenta home is not recommended. There are risks to having a vaginal delivery. The most common risk is tearing around your vagina and perineum that may require stitches at time of delivery. These stitches will dissolve on their own in 4 to 6 weeks. However, they may be sore during the recovery process. We provide and recommend the use of pericare bottles and witch hazel pads for comfort. There's also a risk of infection. If we thought you were developing an infection during your labor course, we would recommend the administration of antibiotics. In any type of delivery, bleeding is a risk. We have medications we can give in order to help stop bleeding, devices we can place inside of your uterus, and surgical techniques we can use to control blood loss. If we are concerned how much blood you're losing, we may recommend a blood transfusion. The risks of a blood transfusion include a very low risk of transmission of a bloodborne pathogen, such as HIV or hepatitis. This risk is cited as about 1 in 2.5 million, and all blood is screened stringently for the presence of these infections. There's also a risk of a reaction to a transfusion, anything from a fever to an allergy that would need to be appropriately treated. In the event that medications, devices, and surgical techniques are unable to control bleeding, the last resort measure to control bleeding is removal of your uterus. This is a very rare procedure and only done in life-threatening circumstances. If there are signs of fetal distress, an alternative route of delivery may be recommended. If you are completely dilated and pushing, an assisted vaginal delivery may be recommended. A vacuum is a suction cup placed on top of your baby's head, while forceps are a device that cup around your baby's cheeks. Under guided pushing with your physician, we will help guide the baby down the birth canal while you continue pushing. The indications for assisted vaginal delivery include fetal distress, as well as maternal exhaustion in the setting of prolonged pushing. The risks for you are higher grade tears that may require more stitches and a longer recovery process. In the setting of a vacuum, risks to the fetus include bleeding under the scalp or bruising or lacerations along the fetal head. In the use of forceps, the same risk of tearing for you is present. For the baby, there is risk of bruising along the cheekbones and irritation of the nerve along the face, which may lead to a temporary droopy smile. All risks to your baby are resolvable and temporary, resolving spontaneously in 1 to 2 weeks. If you are not completely dilated and a sooner delivery is recommended, the route of delivery would be a cesarean delivery. The cesarean delivery has a higher risk of post-operative pain, infection, bleeding, and injury to structures surrounding your uterus. If this route of delivery was recommended, additional discussion and consent would occur prior to proceeding with delivery. Our anesthesia colleagues are going to talk about the specifics of pain control, but in brief, natural methods for pain control during labor include hot water, frequent movement, and use of pressure points. In early labor, we can offer IV narcotic medications, and if you desire an epidural, this can be placed anytime during your labor course as long as you can safely sit still for the procedure. Whether you came in for a scheduled induction, came in because your water broke, or you were having contractions, labor augmentation methods may be recommended as part of your care. We are going to discuss all augmentation methods here. However, we may recommend some or all of these methods depending on where we are starting in your labor course. Prior to going into labor, your cervix is firm and located posteriorly at the end of your vaginal canal. Cervical ripening is the process of cervical softening, thinning, and early dilation. This can take 12 to 30 hours in a normal time frame, depending on how dilated your cervix is when you come in for labor. We have 2 different options for cervical ripening. The first is medication. We use a medication called Cytotec that you can take 6 doses every 4 hours, meaning 24 hours worth of pills. These can be taken orally or placed vaginally. An alternative medication route is something called Cervidil. Cervidil is a tampon-like insertion that's placed at your cervix and releases medication over 12 hours. Mechanical dilation is using a balloon that goes through your cervix and blows up inside of your uterus. We use either a Cook's catheter or a Foley balloon. Either may be recommended based on your provider preference. A Cook's catheter has a balloon on the inside of your uterus as well as in your vagina, whereas a Foley catheter has a balloon just inside of your uterus. We expect that these mechanical methods will help your cervix dilate to 3 to 5 centimeters. Once your cervix has reached that level of dilation, we anticipate the balloon will fall out on its own. If it does not fall out within 12 hours, we will reevaluate and deflate the balloon at that time. While the balloon is in place, you may walk around normally and use the restroom normally. After cervical ripening, when you've reached 3 to 5 centimeters, you are in early or latent labor. In order to continue cervical dilation, we need you to have regular, strong contractions. There are 2 methods of augmentation that we will use. The first is something called an amniotomy, which is just a fancy word for breaking the bag of water, if it does not break on its own. This helps trigger the release of oxytocin, which is the hormone that attaches to the receptors in your uterine muscle and causes it to contract. The other option is Pitocin, which is an IV medication that is equivalent to the molecule of oxytocin, but is placed in your IV and turned up, down, or off to facilitate regular, strong contractions. Often, both of these augmentation methods are used to facilitate labor progression. We consider active labor 6 centimeters. Essentially, this means that we expect a faster progression. You may start to feel shaky or increased pain as your contractions become stronger. We will continue to use augmentation methods such as Pitocin and may place internal monitors as previously discussed if your labor course is not progressing as anticipated or if your contractions are difficult to monitor. Once you reach 10 centimeters, it's safe to start pushing. Pushing can last as long as 4 hours in a normal labor progression, especially in first-time moms. At your birthday party, we anticipate 1 to 2 delivering providers, 1 to 2 nurses, and 1 to 2 corpsmen. As previously stated, pediatrics is not present at all deliveries, but in circumstances, we may recommend that they attend the birthday party as well. This video is designed to be a comprehensive overview of your consent form. However, your provider will be in shortly to answer any specific questions or address additional concerns. We look forward to taking care of you and your family here at Naval Medical Center, San Diego.